Good evening and welcome to the City of York Council Health and Adult Social Care Policy and Scrutiny Committee. Today is the Tuesday, the 9th of February 2021. We have apologies from one councillor this evening. Councillor Warby and Councillor One is substituting at this meeting. Otherwise, we have full complement of the rest of members. Officers in attendance for the meeting this evening in no particular order. Pippa Corner, who is the Assistant Director for Joint Commissioning, Amanda Hatton, the Corporate Director for People, who has responsibility for health and adult social care, and Sharon Stoltz, the Director for Public Health, and of course our democracy officers. Thank you for joining us and assisting us this evening. Do members have any declarations of interest other than at all? Not seeing any signs. No, okay, thank you. The minutes from the November 2020 meeting, which was the last public meeting that was held for health scrutiny, on pages 1 to 8 of the agenda. Do members have anything they want to raise at all from the minutes? Councillor Perrott and then Councillor Culloch.
Thank you, Chair. I noted in the minutes on page 5 there was reference to an explanation on the projected overspend at Haxby Hall coming to our next meeting. It doesn't appear on the agenda, and I just wanted to check whether or not it's going to be covered in the commissioning item that's a little bit further along tonight.
Our officers might be able to pick up on that. Obviously, there was some communication after the meeting last time round, actually from Councillor Taylor, that instigated some communication. I'll let him come in a moment about it, and some responses were received by email, one of which I think was Vicky Japes, had most of the detail in, but our officers might be able to add to that. Amanda, do you want to come in there?
Yeah, it isn't specifically covered in the commissioning update this evening because the agenda was refined down in recognition of the amount of work that was going on within adult services given the impact of the pandemic. I'm really happy to take that offline and do a written response if that's helpful. I'll meet separately about it.
That would be. Thank you, Amanda.
Thank you. I'll let Councillor Taylor come in first, if you don't mind, Councillor Culloch, because I suspect he wants to speak about this item as well.
Thanks, Chair. To save Amanda some work, or at least I think to save Amanda some work, Michael, Melvin, and or Vicky did email me quite a long response, going back a bit now, maybe like 2 months or more, but I'll forward it on. I think at the time I just assumed the whole committee had got it, but forgive me, I'll share it with everyone, and if more information's needed, then we'll take it from there. Does that sound all right?
That's very helpful, Councillor Taylor. Yeah, I do recall, I think it was late November, because I did refer to actually the email, having read the minutes from this. And I think Michael responded initially to your first one, I believe, and then Vicky Japes sent quite a more lengthy update, I think, at that point. So that might be useful. I must admit, I was in the impression it'd be shared with everyone as well. So we'll make sure that is. Thank you. Did you have anything else, Councillor Taylor, that you wanted to? No, right. Okay, Councillor Culloch, then, please.
Thank you, Chair. These are really just tiny typos, but I thought I'd mention them. Page 3, the first bullet point there, City of York is fortunate they have a service which is good or better. Just doesn't quite make sense. I think there's probably a word or two missing there. And also page 5, point 5, performance for 202/210, clearly should be 2021, but they're only typos.
Yes, we'll ask officers to just make some corrections to that before the minutes are signed. Thank you, Councillor Culloch. A couple of things I just want to briefly touch on myself. One I just thought was a bit of slightly peculiar language that was used. So again, it was page 5 in the second bottom paragraph in the delayed transfer of care, and that should be transfer of care, not transference. In one of the lines, it says the department does measure the length of time a customer remains in hospital. And I think that was slightly peculiar language, and whether, you know, patient, maybe it's just me, maybe that's how the hospital would consider their patients, but I just find it slightly strange language. That's my opinion. And then more of a point I think we could just do with an update on page 4, in the increase in mental health concerns. And again, this might not be anything that the officers can answer to this evening, but perhaps something to pick up with the CCG or TUV or both. In that paragraph, it says from April onwards, new mental health workers would be available for practices to employ GP surgeries. And I just thought it would be useful, now we're a few months on, to understand how that training's going on and whether we're still on track for that commencing in April. And a couple of questions that kind of related to that. It would be interesting to know which practices, or is this going to be available to all practices in York, GP practices, and how it's going to be promoted. So perhaps that's something that can be picked up either by officers if they can't answer that, or indeed I'm quite happy to email myself, but I don't know whether any officers can answer anything on relating to that currently.
We can give you an update in relation to the council's response to mental health, but I think if you're talking about CCG and primary care responses to mental health, it might be worth a future update. It might be worth a future agenda item in relation to mental health more broadly.
Okay, thank you. Thanks, Amanda. Pippa's indicated she wants to come in there, so Pippa, please.
Yes, thank you. It was just to say I suspect that is referring to some money that came through the NHS long-term plan into primary care through primary care networks to create new roles around mental health. But I think for further detail, we'd need to double check with the CCG.
Okay, thank you. Right, okay. All right, with those changes and clarifications, if there's nothing else, members, then I'll be happy to sign the minutes when the point I'm able to physically, that is. Right, so that takes us to the next item. We don't actually have anyone registered in public participation this evening at all. So we'll go straight into the COVID update, and the Director for Public Health, Sharon Stoltz, is going to give us a verbal update in relation to work around COVID, and she kindly shared with members some graphs and data, which I think was probably presented at CSMC last night. I haven't seen CSMC webcast yet, but Sharon, if you want to come in and give you an introduction, if you wouldn't mind.
Yes, I was intending to go through the presentation if that's okay, if one of the technical support people are able to get the presentation up for us. That's great, so that anyone who's watching the webcast will be able to see the presentation as well. So what I'm going to do is update some of the data as I go along with the most recent figures for today. But if we go on to the next slide, please. This is what I was intending to brief you on this evening. The outbreak control plan. the epidemiology, so that's just the local picture of what's happening in the pandemic around case numbers, etc. Talk a little bit about certain settings that we're working with across the city. Give you an update on testing and contact tracing, and then make you aware of any key issues emerging that you might want to test me on later. So on to the next slide, please. Our current outbreak control plan was approved by the Outbreak Management Advisory Board last June, I believe it was. There are 7 national themes in the outbreak control plan that are given to us nationally, as you can see there on the slide. And then we have 2 local themes that we've added around communications and mental health. Our current outbreak control plan is due to be refreshed by April, and so in future updates to the committee, I'll be able to update you on any changes to that plan. On to the next slide, please. So this shows a slide of what's happening with our case numbers at the moment. And as you can see, the red line being York, you can see what happened in the first wave of the pandemic, where we were in terms of the second wave, that was towards the, with the peak around the 6th, 7th of October. And then the most recent peak that we've seen in January, and how those numbers are now coming down, so that we're currently below the regional and national average. So just to give you the most up-to-date figures for today, our rate of today is 152 per 100,000 population. The national rate is 222 and the regional rate is 182. So even though our peak was considerably higher than the one for the region there, we've managed to get a grip of those case numbers and have now come down to below the regional average, which is very positive news for the city. On to the next slide then, please. So what we can see, again by this slide, that in the last peak that we had, we were seeing the highest case numbers in people aged 15 to 34. What we've seen through this peak is an increase across all age groups, which is now starting to fall. But this time we've seen the highest number of cases in people of working age, so the 35 to 49 age group. And as you can see, even though cases have dropped overall, that is still the group that has the highest number of cases at the moment. So on to the next slide, please. This gives some information on what we call the positivity rate. So this is the number of tests that are taken, and the proportion of those tests that come back as positive. So the PCR tests, these are the tests that are normally offered to people with symptoms of COVID. However, in York, we're also doing targeted PCR testing in localities of the city that have had high case rates. So we've been doing targeted testing in the Acomb area. We've had the mobile testing site at Acorn Rugby Club for a couple of weeks now. And we also have a mobile testing unit at Haxby. And so because there will be asymptomatic individuals that are accessing those PCR tests, that might be having an impact on our lower prevalence with PCR testing there. Having said that, that rate is compares very favourably with the regional and national rates. The lateral flow tests then, the rapid lateral flow tests, we've discussed these before at this meeting, are targeted to people that don't have symptoms of COVID, symptom-free testing. And as you can see, their positivity rate there of 0.44%, which again compares quite favourably with national and regional rates. Over to the next slide then, please. This shows York's position compared with other local authorities across the Yorkshire and Humber region. So for some weeks through January, York was at the top of this league table. For a number of weeks, we had the highest number of cases in the region. As you can see, as our numbers have started to fall, we're in a much better position now regionally, with a number of local authorities now with a higher rate than us. So we keep a close eye on this to see how we compare with the rest of the region, and hopefully our numbers will continue to fall. On to the next slide then, which shows the COVID rate per electoral ward across the city. And as you can see, we have a number of wards highlighted in green there that have seen a statistically significant fall in the number of COVID cases. And then the wards that are coloured orange, where the rate is falling, but it's falling more slowly. So this is something that we also keep a close eye on. And this data, together with other data we've got access to, helps us to determine where we need to do some targeted testing or additional communications work. On to the next slide then, please. So this shows what's happening with hospital patients in hospital with COVID. We need to remember that not all patients at York Hospital will be York residents. The York Hospital site does take patients in from a wider geographical area. But looking at the York site gives us the best indication of what the activity is. And as you can see, the first wave, there was a peak of patients there. It was then very low over the summer months, and we saw another bit of a peak there again in November time. But just as we saw the peak of cases, the spike in cases, we've also seen a spike in hospital admissions there. And it gives you a better understanding, I think, of how busy the NHS has been when you compare the size of this peak to the one that we had last spring. I'm very pleased to say that those numbers are now falling. And as our case numbers fall, and as more people in the high-risk groups are vaccinated, we would hope that we would start to see those numbers fall even more quickly. So a positive picture there in terms of the hospital. Just to give you some up-to-date information on this. I was in a meeting earlier that said we have 109 COVID patients on the York Hospital site at the moment. So those figures will have dropped even further than you can see on this graph here. So positive news. On to the next slide, please, which shows what's been happening with deaths since the start of the pandemic. So as you can see on this slide, we again, this represents weeks of the year. So we had the peak in deaths, which again were lower, and we've seen this recent peak of deaths, which reflects the increased hospital activity that we saw on the last slide. Last year, if you look at the whole of 2020, we saw 140 excess deaths in York. They won't all have been COVID deaths. We looked at all age, all cause mortality. We are intending to do some further analysis of those deaths once we have a bit more time. Once cases fall a little further, we'll have a little more capacity within the public health team to do a further analysis of those excess deaths, which I'll be very happy to share with the committee once we've done that work. So I would hope that analysis would be ready in April time. And then if we go on to the next slide, this gives you an understanding of what's happening in some of the settings across York at the moment. So we have a much improved picture with care homes. We only have 6 care homes at the moment, 5 actually today. So that number's come down, and the latest outbreak we've seen in a care home was yesterday. So that brings you completely up to date with care homes. And the numbers of school-age children have also improved. So as of today, we have 19 children of primary and secondary school age that have tested positive. They are not necessarily children who are attending school at the moment. That's children of primary and secondary school age, some of which might actually be being educated at home at the moment. So on to the next slide. This shows what's happening with our contact tracing service. So I think we've seen this graph before. The red line determines when our local contact tracing service first started back in October. We're doing very well in terms of our case numbers. The most current figure is that we are able to complete over 96% of the cases that have been referred to us by NHS Test and Trace. So again, the contact tracing service is doing very well. On to the next slide then, please. This is to give you an indication of what's happening in York with the UK variant. So this is the UK variant, sometimes called the Kent variant, because of it started down south. York, North Yorkshire, to a certain extent, but particularly York, has been troubled really with this new variant, which is one of the main reasons why we believe we saw the spike of cases in York in January. So we estimate at the moment that 81% of the cases that are being picked up through PCR testing is due to the new variant. And as you can see, that has been consistently higher than the average for the region there. Although the region are catching up. So this UK variant has become the predominant variant now across much of the UK, and we've certainly seen that in York and are seeing it now across the region as well. Just to say something then about the other variant, the South African variant that's been discussed quite a lot in the news over the last few days. We've not picked up any cases of the South African variant in York. There have been 2 cases identified in Scarborough that you might have read about in the media. Those 2 cases were linked to travel, and the North Yorkshire Director of Public Health is confident that those 2 cases have been quarantined, and that there won't be any further infection arising from those 2 cases. You'll also be aware that there is what's called surge testing happening now in some parts of the country, where they are picking up cases of the South African variant. I think about 147 cases nationwide picked up there. Public Health England are monitoring those cases very, very carefully and are working with those local authorities where cases have been identified to put in place surge testing. And just to assure the committee, we have those plans in place for York. And so if we needed to trigger any surge testing, we would certainly be able to respond to that. But as I say, no cases at the moment. I suppose it's also important to say that viruses do mutate. It's what they do. It's normal. The flu virus mutates every year, so it's not surprising that the coronavirus is mutating as well. It's not unexpected. There's about 100 different variants of the COVID vaccine at the moment, but only those 2 that have been identified, the UK variant and the South African variant, that are of concern. And that's really because we know that they're more infectious and spread more easily. So on to this next slide then. Sorry, can we go back to the community safety slide? Thank you. So this slide really just gives you a snapshot of some of the enforcement activity that has been taking place across the city. So there is a community safety hub that meets daily to review any antisocial behaviour events across the city. And one of the things that we've developed as part of our pandemic response is to integrate the work of the community safety team with the work that the public protection team does. So environmental health, trading standards, the COVID marshals, as well as North Yorkshire Police. So any events that are referred to the council, they're reviewed daily at that meeting. Any concerns around breaches of COVID regulations, for example, by businesses, all of that is looked at on a daily basis, so that our resources that we have in the council can be deployed to the most effective use. It's working really, really well, and it's one of the positive developments of the pandemic that I'm sure we'll want to continue with. So just to give you snapshot then of what the COVID marshals have been doing. So as you can see from the slide there, they're interacting with businesses. They are doing foot patrols in those areas where we've had concerns raised with the council around groups gathering outside takeaways, for example. They do foot patrols in those areas. They've handed out a significant number of face coverings to those people who should be wearing a face covering and are not. And they've also picked up a significant number of discarded face masks. It's quite concerning that there's a minority of people think that it's okay to just discard used face coverings in our streets. That clearly is not acceptable. It's a source of infection. People should be either discarding their face masks in a bin, or they should be keeping them in their pocket and taking them home and disposing of them there. But nevertheless, we have a problem with some people just discarding face masks, and as you can see, the COVID marshals are doing a very useful job in safely, so following infection prevention and control measures, safely picking up and disposing of those face masks. And again, a snapshot survey of the COVID marshals showed that over 99% of people have been satisfied with the service that they've received. So I thought you might be interested just to see a little bit of evidence really of how well that service is working. On to the next slide then, which gives you again a snapshot as to how well York is doing with the COVID vaccination programme. So COVID vaccination is led by the NHS, but as a council, we are supporting them with the vaccination programme. For example, I've redeployed some nursing staff from the Healthy Child Service to support vaccination, and the council are supporting in a number of different ways. So York is doing amazingly well with the vaccination programme. And just some stats there. We've estimated that just under 100% of people aged over 80 in York have had their first dose. That again, around 100% of people aged 75 to 79 have had their first dose, and making really good progress with the rollout of the vaccination programme to 70 to 74-year-olds. And all care homes have now been offered the vaccine. One of the reasons we say estimated number is because we haven't got a completely accurate denominator. So we know how many people have been vaccinated, but when we're looking at population estimates, we're still reliant on using government estimated populations. It won't be until the next census that we'll be able to have a really accurate number of people living in York in the different population age groups. So this is estimated, but it's not far out. It's pretty accurate, I would say. On to the next slide, then, just to highlight some key issues for you. So in York currently we have 3 testing sites for rapid symptom-free testing. That's York University, York St John University, and this week we opened the new testing site on the community stadium complex. The government are now expanding testing to businesses with more than 50 employees. So at the moment, all businesses can send their staff along to one of our 3 symptom-free testing sites. Businesses can continue to do that, or if they have more than 50 employees and they want to set up their own testing site, they can apply to government to do that. What we're doing with businesses as a public health team is the same offer that we did with schools, in that we supported schools to set up their own testing sites. We provided advice to them on how to do that. We provided training to staff who will be doing the swabbing, and also did site visits and provided quality assurance and ongoing support and advice to those testing sites. So that's something that we'll be doing to any businesses in York that are interested in going down this route. I mentioned that we're doing pretty well in terms of what's called completions with test and trace, but we still have a significant cohort of people that we haven't been successful in having face-to-face contact with them. So we make 2 attempts to contact people by telephone, and if we're not able to contact them by telephone, we will do a home visit. And we have about 33% of contacts who we're not able to contact either by telephone or home visit. We do supply written material when we do a home visit. And so there are concerns around compliance with social isolation. So if you've tested positive for COVID, it's actually a legal requirement that those individuals stay at home. But we know that that isn't happening in every case. So we've started doing some work with the business intelligence team to cross-reference names and addresses to make sure that we have the right contact details for individuals. We will be making more than one home visit in future at different times to hopefully be able to make contact with people. And if we still fail to establish contact, and we've been able to establish they're not in hospital, for example, then we will be taking this information into the daily community safety hub review to have a discussion around any additional enforcement we might want to do with those individuals, because clearly we're not going to be able to get a real grip of the pandemic in York and get to a point where we have no community transmission of COVID and only isolated outbreaks unless everyone complies with social isolation. So we've started doing some targeted work around that. We're expecting the government to publish their roadmap out of national lockdown this month. So the government have already given some announcements around schools and universities, and we're expecting the roadmap to be published with a timetable out of national lockdown. Until that roadmap is published, we're not going to be 100% sure of what's in that. But what looks likely is that we won't have a return to the old tiering system, because clearly it didn't work. It certainly didn't work for York. And so what we're likely to see is lifting of restrictions sector by sector is our best guess. And then also just to say, as I mentioned earlier, we'll be planning a refresh of our outbreak management plan to be approved by the Outbreak Advisory Board. So that's next slide is just then questions. So that's hopefully been a useful overview as to where we are in terms of the pandemic, but I'm happy to take any questions, Chair.
Thank you very much, Sharon. It's quite comprehensive, I think. Yes, we've certainly got members waiting to ask a few questions, and Councillor Hook's been waiting some time, so we'll start with Councillor Hook, and then I think you'll have to bear with me. There's several. I'm not sure I'll get people in the right order, but I'll make sure everyone gets the opportunity to ask the question. So,
Okay.
Councillor Hook first,
Thank
please.
you, Chair. And thank you, Sharon. That was really interesting and quite good that all the numbers are coming down quite nicely, which is great news. I was just a tiny question. You mentioned the South African and the Kent variants, but what about the Brazilian one that they keep mentioning as well?
Okay, so at the moment, as far as we're aware, there have been no cases of the Brazilian virus in the UK. And obviously we want to keep it that way, which is why there have been all the discussions nationally about quarantining people. So those measures are with the central government at the moment. That's one of the reasons why we're putting in plans in place, though, for surge testing if we needed to. So Public Health England have a very effective national surveillance system. So if the Brazilian virus were to get into the UK, they would pick it up very quickly. And any local authorities that are identified as having the virus, we would work with Public Health England to ensure that we responded very quickly and put that targeted testing in place. But at the moment, we only have the UK Kent variant, and fingers crossed it will stay that way.
Thank you.
Thank you. Councillor Culloch, then Councillor Heaton.
Thank you. This is a slightly tangential question, but I find myself wondering what has been happening with flu all this time. Has it disappeared? At this time of year, we would normally expect, of course, hospitals to be dealing with flu cases. Is it that because of all our social distancing and care over hand washing and so forth that we've actually seen a reduction in flu, or what's the story?
So you're absolutely right, Councillor Culloch. There is very little flu around at this time of year, and I think there are probably two key reasons for that. One, as you rightly point out, all of the infection control measures that we've been encouraging people to follow against COVID also work against other respiratory diseases and also norovirus. So not only have we seen very little flu around this year, but we haven't seen very much norovirus either. And that often closes care homes and hospital wards at this time of year. So that's kind of a kind of additional benefit, really, of all of the work around infection prevention and control. The other issue is we had an expanded flu vaccination program this year. So the NHS went all out to vaccinate as many people as they possibly could with the seasonal flu vaccination. And the numbers have been higher than they have ever been in terms of take up of that vaccine. And also the eligibility was extended as well for seasonal flu. So I think a combination of the vaccination program and the measures around infection prevention both will have had an impact on flu. It's interesting, isn't it? Because, you know, people die from flu every year, but the media don't report it. And so it goes under the radar, unlike COVID, where every COVID death gets talked about in the media. But if we've been able to manage seasonal flu this year, then maybe, you know, we'll be able to better manage seasonal flu in other winters and help prevent avoidable deaths. So another added benefit, I think, from the work that we've done this year.
Thank you. Thank you.
Councillor Heaton, please.
Thank you. Thank you, Sharon. Yeah, Near's hoping we take a lot of lessons from both how we've responded to COVID overall, but also, as you say, other areas forward, and we really examine those. Just want to look at the hospital numbers that you brought up there. Obviously, we talked about the acute numbers coming down. On that graph you were showing, the ITU numbers seem to have crept up slightly. Now, they're obviously not at the peak from last year, but they do seem to have crept up now. Is that something to be wary of in terms of developments with the virus, or is it simply a matter of the numbers being relatively small and so it's pronounced a bit more?
I think that the numbers of patients in hospital and in ITU reflect what's happening in the community at that time. And so because we saw this massive spike in cases of COVID, we obviously had a higher number of elderly or vulnerable people in the population that were being exposed to the COVID virus as well. And that's what's led to the spike in hospital admissions. And of course, if you've got a higher number of people with COVID, a higher number of people in hospital, inevitably you're going to see a number of those patients become very sick and need intensive care. And then because treatments have changed, people are surviving with COVID better than they did in the first wave. So we're finding that people are staying in hospital for slightly longer, and they're staying in intensive care for longer as well. Those intensive care numbers are now starting to fall. But once you go into intensive care, you're often in there for maybe a month or longer. So what the data doesn't tell us is how many new patients have gone into intensive care. It just shows the cumulative number that are in there at the moment. The intensive care numbers were not shared today, but I know from a meeting I was in on Friday that those numbers have stabilized, and they're not seeing the same pressures on intensive care either. And that they were seeing in the hospital, even 2 weeks ago, the numbers are significantly falling. And as more of the elderly and vulnerable become vaccinated against COVID rather, that will obviously help to reduce the number of hospital admissions and reduce the number of people who are likely to get very sick with COVID. So we'll see that improvement in intensive care numbers as well.
Thank you. And just to fill out that picture, what is the ITU capacity at the hospital? Look at those numbers.
Do you know, I can't remember. I don't know whether Amanda can remember. I know they've had surge capacity around ITU. So they've got their peacetime number of intensive care beds, and I know they've increased them. But I'll have to follow that up with an email after the meeting, because the number just isn't on the tip of my tongue to give it to you now.
Thank you.
Thank you. Councillor Taylor, then Councillor Perrott, please.
Thank you, Chair. I've got a fair few questions, so I'll just ask two for now, and then let Anna and others step in, and then do my others later, just so I don't hog proceedings. Thank you for your report, Sharon. I want to ask a couple of questions. Firstly, on the COVID marshals. Is it possible after this meeting that we can get a breakdown of those figures when we say interacted with? I'd like to know what interacted with represents, just because the vague stuff really bugs me, and I can't really do much with that in my mind. And I'm sure it's logged somewhere, because there's a difference between an awkward conversation with someone who's not compliant and popping into a business to say, hi, how's it going? So it'd be good to get a feel for that, if that's possible. It's more of a request than a question, I suppose. But anyway, you can answer that if you think it is possible. And the second question is, it says that 99% of people are satisfied with the COVID marshals. I'm just wondering who we're asking. And I'm asking that question because I'm sort of thinking, I'm assuming the COVID marshals will have some difficult conversations that some people won't like to have. And in my mind, I would imagine that number to be, or that type of bad experience to be greater than 1% because of people not being happy with being pulled up potentially. Or am I looking into that too much? Cheers.
I don't have the specific. I can give you a general answer now, but I'll have to follow up with the specifics by email, because I don't manage the COVID marshals, so don't have the information right at my fingertips. But the engagement with businesses is really targeted to those businesses that we have some intelligence about, where there's been concerns raised about them not following the rules. So, a particular premises that is open when they're supposed to be closed, concerns around lack of social distancing, and not enforcing wearing of face coverings, for example, and as people are exempted. So that's the type of activity that they do. But I'm sure that I'll be able to get a breakdown of that from the manager of the service. And then the question of about who have they asked in terms of their survey, I don't know the answer to that. So I can get hold of that and email it round.
Cheers. I'll be quiet for a bit, Chair, and come back. Cheers.
Thank you. Councillor Perrott.
Thank you, Chair. You'll be relieved to hear that while I did have 3 questions, a similar one's already been asked, so I'm down to 2. So firstly, I think just a big thanks to you, Sharon, because the data and sort of how it's presented has been really helpful for sort of putting things in context, and especially around the numbers of admission, just highlighting the challenge for NHS staff and what they've been facing. So thanks for that, because I think it gives us a really clear idea of just how much capacity's been strained, and I'm sure everybody will want to put on record again our thanks for everything that everyone's doing. So question wise, can I ask around the care home infections and outbreaks, just because it was a bit difficult to gauge, because we get current figures on how many there are, whether or not this is sort of typical, whether that's sort of, I think it's 5 you said that have got them currently. Is that sort of typical for a week by week basis? Has it fluctuated as obviously infection rates have peaked and troughed? And in terms of that as well, do care homes sort of seem to go in and out of figures when there's just a single case for infections, for example, just based on a staff member over a number of weeks? It'd just be useful if you could give us a bit of a longer term breakdown as to whether or not that's to be expected and similar to other local authority areas. And my second question was around vaccinations. So I'd spotted just over 1,000 people had had the second dose, but there's around people getting that second dose on time, because obviously a lot of people who had it earlier on, who were especially in their 80s and quite clinically vulnerable, are now really concerned that the time period's elapsed, and I've had a few residents get in touch. So it's possibly an unfair question to ask if you could shed any light on when we're going to see the rollout of the second dose on a wider scale in York, but if you can give any indication on that, that'd be appreciated.
Okay, so Amanda and Pippa might want to add some additional information around care homes, but just to say that York is in a better position in terms of our care home outbreaks than other local authorities across the region. And in fact, I was on a call today with colleagues from North Yorkshire, and they were talking about their care home outbreaks, which are significantly higher than ours in York. So the numbers do fluctuate a little bit. The infection rates in care homes will, to a large extent, reflect the infection rate that is in the community. So many of the cases, positive cases that we're picking up in care homes are in asymptomatic staff. Because we do regular weekly testing of all staff in care homes, monthly testing of all residents, whether they have symptoms or not, what we're picking up is quite a lot of asymptomatic staff. And it's important, I think, to recognise that they have not been, most times when we go in and we go into that care home and we look into what's happening in that care home in terms of those infections, most often the exposure to the infection has happened outside of the care home, not in the care home. So the staff have been exposed to infection in the community. Just as any of us could be exposed, as we go shopping, etc., etc. Where we have had outbreaks of where we've identified positive cases in residents, there is always a site visit. So we would go into that care home, the infection team, control team would go into that care home. Adult social care would be going in and looking very carefully at the protocols and the procedures within that care home, looking at donning and doffing of PPE, etc., etc. And so we have had a handful of care homes over the course of the pandemic where we've had particular concerns. And there has been ongoing work with those care homes to get them back on track. But they have been a handful. By and large, it's been asymptomatic testing we've picked up. And actually, the fact that we have 5 today is pretty good. That's one of the lowest rates in the whole of the region, and York, I think, is acknowledged as having good practice in place when it comes to the way that we've been managing the pandemic in care homes. Obviously, it's very difficult not to have any infection at all in any of these settings. But the fact that we're doing the regular testing means that we're able to pick up any infection really, really quickly. And we're able to get in there quickly as well and prevent the spread. In terms of vaccinations then and the second dose, obviously, the vaccination policy is determined nationally. The government determines national policy based on the advice from the Joint Committee for Vaccination and Immunisation, the JCVI. The vaccination policy in this country is to vaccinate as many people as possible with first dose. And so this is the reason why people are now having their second vaccination 12 weeks after the first vaccination, as opposed to 3 to 4 weeks, which was what most other countries have done. So the people who will have had their second dose are the people who will have been in that first tranche of the vaccinations before the government changed the policy to be 12 weeks apart. So anyone who will have already been have had an appointment for their second dose, their GP practice in most cases honoured that second appointment, and so they will have had their second dose. we'll also now be starting to get a cohort of people who are, it's 12 weeks since their first vaccination, so they'll be invited for their second vaccination now. So by the end of March, I think everybody in those most vulnerable groups should have had their second dose. So that's kind of how that's working. So everybody will get 2 doses, but so, you know, most people are going to have to wait that 12 weeks between their first and their second.
Thank you. Councillor Heaton next, please.
Thank you, Chair. Just following on vaccines then, what's the actual picture on the vaccine supply coming through? Because undoubtedly we'll see changes as time goes on, but is there a situation of there being gradual slowdowns and increases? Is it coming in sort of like fits and starts? What's the current situation with that?
So the vaccine supply in York has been good. The only issue that sometimes has happened is it hasn't necessarily arrived at the time that it was expected. So there have been a couple of cases where, you know, GPs thought the vaccine was going to arrive. They've sent out letters and appointments to people, and then the vaccine hasn't arrived at the time that they were expecting it, and they've had to contact people to cancel and reschedule appointments. So that has happened on a couple of occasions. But the vaccine supply to the hospital, for the staff hub, vaccination hub, to GP practices, and the GP Nimbus site has actually been okay. There haven't been any concerns at all. The national vaccination site that we've got at Askham Bar, so we've got 2 sites at the old the Askham Bar Park and Ride. One of them is a GP site, and the other is a national site. It's a bit confusing because they're both managed by Nimbus, but people don't realise that one is a local and one is a national. The supply to the national vaccination sites, there's been some concern about volume of vaccine arriving at those sites for all of the appointments in some parts of the country. But again, we haven't had any difficulties in York. So, you know, touch wood, it continues that way. And, you know, we'll be able to continue with a very rapid rollout of the vaccination programme that we've seen up to now.
Thanks. And when we're saying there is that slight delay in that small number of cases, is that just a slowing down and they come with ones that would have arrived later, or is it everything slightly slowed down? And
no, they just there's just been a logistical hiccup somewhere, you know, snow, ice,
right.
And the delivery van hasn't quite turned up at the time it was expected. Might be later that day or the next day. So it's mainly been logistical issues of getting that order of vaccine to its intended destination at the time that it was originally promised. So there's no slowdown of the vaccine supply, put it that way.
Thank you.
Thank you. We'll go back to Councillor Taylor next, and then it'll be Councillor Culloch thereafter.
Thanks, Chair. Thanks for fielding all these questions as well, Sharon. I do admire your perseverance with us all. I've got 3 questions relating to vaccination. I'll list them all in one go, and if you need any repeating, don't be shy to just ask. First question is, what happens with those people who don't necessarily accept their invitation for a vaccine? Is there a follow-up, and how might that work? Second question is around sort of handling capacity. So in my mind, and I might be wrong here, I'm thinking older residents who go through, more vulnerable residents, might need people supporting them to go through the centre, therefore taking up more of the available capacity we have. We're going to reach a point where you've got those people coming back for the second dose and younger people coming in for the first dose. Is the and with that in mind, I'm then thinking the choice then for us is, do we slow the pace of vaccinations, or can we grow capacity safely to continue the pace, but with those different types of people? And then the final question is, I'm assuming this is being treated as a sort of healthcare setting, and therefore the CQC would want to make sure that it's working right. And if so, will they inspect it at some point soon? Because it was registered in December, I believe. But I can repeat any of them if need be, but they're my 3 questions.
No, that's fine. So in terms of what happens with people who don't take up their offer of a vaccine for whatever reason, there is going to be a mopping up. So everyone who has a vaccination, that vaccination is recorded on their GP health record. So there will be a process, and local authorities have been asked by Department of Health and Social Care to support GP practices to do this. There will be a mopping up. So GP practices will be able to produce a list of people that haven't been vaccinated. And then the idea is that local authorities will work with those GP practices to target those individuals that haven't been vaccinated, whether they need, whether they might be somebody who needs further information to give informed consent to be vaccinated. It might be that somebody needs additional support to be able to get to a vaccination centre, whatever that might be. So there is going to be a mopping up, and there is a commitment that 100% of people will be offered the vaccine. Obviously, it's voluntary and people have the right to refuse it, but everybody will be offered. And so in York, there will be extensive efforts put in place across the city to work with GPs to ensure that everybody is offered. So I can reassure you there. In terms of handling capacity within the sites, we know this is an issue, and some conversations have already been taking place with Nimbus around this, and I know they're already thinking about it and working out how they're going to manage it. So there are volunteers at the vaccination sites to support people, to guide people, etc. So there are volunteers on site. There are obviously then administration staff, there's the vaccinators. If we're talking about elderly people or people who are clinically vulnerable, they may well have been accompanied by their carer or by a relative. And so that means that the sites can sometimes get very busy because of the number of people that are around. That's easing off at the moment because the very elderly and the most vulnerable have already been through, and they're starting to see younger people now. So that's eased off. But certainly Nimbus are very aware of the risks that you describe, that as we start to get more people coming through for their second and people coming through for their first, how they're going to manage that. And they're already thinking about, do they reconfigure appointments? Do they give longer between appointments? Do they aim to have fewer people through? So they're actually looking at that now, because it's already something that they're aware of, and I'm confident that they will have put measures in place to be able to manage that when we get to that point. All vaccination sites have to be CQC registered. There's also a quality assurance process that's managed by NHS England. So every vaccination site has to comply with the National Standard Operating Procedure. They have to have a pharmacist on site. They have to have a doctor, etc. But the bulk of that is done through a paper exercise. So vaccination sites have to send back their plans which evidence how they are meeting the clinical requirements and safety requirements of that site. The vaccination sites in York then have had a local health and safety visit. So if we think of the two Askham Bar vaccination sites, they've had site visits from the health and safety team at the hospital, and also they've had site visits from the infection prevention and control team from my staff. So we've had people from the public health team go in, and also the council's health and safety team have gone in as well. And so there is quite a lot of quality assurance and oversight that we're doing locally around that. And there is an ongoing dialogue with Nimbus around any recommendations that are made following those visits for, around issues around waste disposal and ensuring adequate ventilation are some of the things that have come up so far. As to whether the CQC intends to go out and inspect these sites, I can't answer that, but I doubt if CQC would have the capacity to be able to go out and inspect every single site, because there are hundreds of them across the whole of the country. But again, what we've done in York, hopefully I can give the committee assurances that, again, we've taken a whole city approach. And we're saying that even though, we've got these vaccination sites in York, the council isn't responsible for them. We don't commission them, but we will work together with those sites to make sure that they're safe as far as possible, safe and effective places for our residents to be able to access those services. So there are quality assurance measures in place and an ongoing dialogue. And if we become aware of any issues, then we have weekly discussions with Nimbus, and we're able to raise those issues and work through them together, because I think that's always the best approach. That if any issues arise, that you actually sit down and work through them as partner agencies. And I've been very impressed by the staff working at the site, their willingness to take on board feedback, and they're passionately committed to providing a good service, and a lot of praise coming back from the experiences that people have had. But inevitably, because of the thousands of people who are going through, there are bound to be a couple of isolated incidents where people's experience has perhaps not been as positive.
Thank you, Sharon. It's kind of linked in some ways, because now we're talking about vaccination specifically and the cooperation with Nimbus Care that the council has. I've noticed this week in particular, Nimbus and some of the GP practices have been proactively making a call forward for over 70s to make appointments now that haven't already had the first immunisation. are we getting at a point, would you say, that we might be getting close to calling the next group of people, so group 5, the over 65s? And is this something that the Department of Health would have a say in, whether you could commence that, or whether have we got flexibility if we feel that we're getting close to, you know, having put a call out and most of the over 70s have had an opportunity to come forward? Will we start next?
Yeah, there's a certain degree of frustration locally that there is no flexibility. GP practices and Nimbus care can only start to invite the next cohort once they get the go-ahead from government to do that. So the government has a target for vaccinating or offering vaccination to the first 4 cohorts by the 15th of November, and York is on target to meet that. And then the government will give the go-ahead to start to invite cohorts 5 to 9. So local areas don't have the flexibility to start inviting people earlier.
So that's the 15th of February, do you mean? I'm guessing,
Yeah.
Yeah, 15th of February.
15th
So from
of
that
February.
From that point, if the government says we can start, basically.
Assuming the government gives that go ahead, and then obviously assuming that the vaccine supply continues to be sufficient as it has up to now, then they will start to invite in order the other priority groups.
Okay, thank you.
It's a nationally driven process, not a local process.
Yeah, thank you. Okay, Councillor Culloch next, then Councillor One.
Thank you, Chair. The question you asked is very close to the one I was going to ask, although I do have 2 others. So I'll take a leaf out of Councillor Taylor's book and I'll put them all on the table. Slightly confused because I'm aware that in other parts of the country, certainly in some parts of the southeast, already other cohorts have been invited to come forward, and already over 65s and other groups are receiving vaccination. So the national policy seems to be a little more confusing. It may be that they're relating to other concerns in those areas, but I'm really pleased with the feedback we seem to be having in York, as you say, and the overwhelming response seems to be that people are having a good experience when they do go forward for vaccination. The other questions I was going to ask are they're just evidence of vaccine refusal. We're aware that in some parts of the country, and particularly concerning, of course, where those who are working in care settings are refusing to have the vaccine. Whether that's an issue in York, what's the lack of uptake as far as you're aware, and what's being done about that, if anything is being done or could be done. And the other thing we're aware of from time to time nationally is the situation where vaccine is being wasted, maybe at the end of a shift. There seems to be some surplus stock, and then what an awful thing if it's then not being used. Is that the case in York? Are we having experience of that? And again, what might be done to address that?
Okay, so your first question links to your third question. So what all areas are being encouraged to do is have a reserve list of people who would fall into one of those 9 JCVI cohorts, who can be called at very short notice to use up any vaccine that's available at the end of a session. So what vaccination centres do is they plan their appointments assuming that there are 5 doses of vaccine per vial. And then what they often find is that there's enough for one dose left, or they have no shows. So they're, people have been booked for an appointment and for various reasons, they may not turn up. And the last thing anybody wants to do is throw away any vaccine. So what some areas are doing, and we're doing this in York as well, is that there will be a kind of, there'll be a list of people who may not be in the first four cohorts, but they might be in the other cohorts. If they've got a telephone number for them, they can email them and say, right, can you get in the next hour? And if you can get in the next hour, you can be vaccinated. So there's none is wasted. And so that's certainly happening. And also there are all sorts of rumours going around about who's been vaccinated and who hasn't. And of course, without knowing the detail of that individual and why they were invited for a vaccine, if it appears they were outside the priority group, it's impossible to comment on that. Certainly in Humber Coast and Vale, York sits as part of the Humber Coast and Vale system. The decision has been made to, as far as possible, follow the national guidance and stick within the national guidance. But within that, have that reserve list of usually key workers who can be called in a very short notice so that no vaccine's wasted. That is certainly happening. And then in terms of evidence of vaccine refusal, I don't have any hard data on this yet. It's not being captured in any way that can be usefully shared at the moment. But anecdotally, I understand that there are very few refusals. We're not seeing it as a major issue. I think I've heard of a number of cases of staff, particularly younger staff, who perhaps have been concerned about being vaccinated, but it's often because of misunderstanding or a lack of information. And once somebody has sat down with them and explained to them the countered some of the old wives' tales with scientific evidence, there are very few refusals. Obviously, it's people's right to refuse. We don't have a policy of compulsory vaccination in this country, not even for health and social care staff. So we strongly encourage staff to be vaccinated. I consider it to be their professional duty to be vaccinated so that they're not at risk of passing infection onto their, the people that they're caring for. But it is voluntary. The Departments of Health and Social Care do want to collect data on number of refusals. So I'm sure the data will become more accurate as time goes on, but we rely a little bit on anecdote at this stage.
Thank you. Councillor Wong, please.
Yeah, thank you. It was a question going back to ongoing testing. Obviously, that's going to be important to really force the number of cases right down. And you were talking about trying to expand lateral flow testing into more workplaces. And is there a worry that COVID is spreading in workplaces? Is there any evidence of that? What about schools and universities that are at least partly open at the moment?
Okay, so testing at the moment is already available to schools and universities. And we're getting that data through. So we got a pretty good picture of what's going on in schools and universities. One of the reasons why we're interested in working more closely with businesses is we can see that most of our infection rates now are in working age people. And if you're unable to work from home and you have to go into work, then those are the people that we're particularly concerned about, because they're the people who are most at risk of being exposed to the virus and therefore becoming infected and then possibly infecting others. So even though we've got people are already able to access one of the 3 testing sites we've got in the city, obviously that's not quite as convenient as if you can be tested at your workplace. So one of the reasons why we're now starting to do this work with some of the larger businesses is to say, are you interested in working with us to have on-site testing? Simply because it's going to be easier for people. They can nip out in their coffee break or whatever and have a test. So that's why we're tending to focus there. Not because we think that they're necessarily sources of an infection themselves. It's more because that's obviously where we've got the highest risk. So making testing as easy as possible for those people is something that we're wanting to do.
Thank you for that. I should just hold my hands up and say I have an interest in this because I work in the university, and about half an hour before this meeting I nipped across the road and had a test and got the result 10 minutes before the meeting started. So it's, it is a really useful thing to have.
Yeah. So actually being able to offer that to other businesses across the city and their employees would obviously be of benefit. So that's kind of our next step that we're wanting to work towards.
Thank you, Sharon. Likewise, my employer, the railway, I'll say the railway broadly, is going to be doing something similar in York. I haven't started yet, but I understand that's going to be very imminent. Is there any data at all on outbreaks in workplaces at all in York? Have we seen any large outbreaks, or has it been really a case of 1 or 2 incidents and perhaps a lot of people off because they're self-isolating because of it, even though they might not have been infected themselves? Do we have any data?
So we do. We do have data on where cases are linked to particular businesses, and if we can see that a particular business has had a cluster of cases, we will do follow-up work with that business, and if necessary, we'll do site visits with them. And we've done a number of site visits and walkthroughs with different businesses, advising them on additional infection prevention and control measures that they can put in place. We haven't had any major outbreaks on the scale that you've read about in the press. They tend to be clusters of cases, maybe 8, 10 sort of cases. We haven't had a situation where, we've had hundreds of people off. They've been smaller than that, and businesses, without exception, have been willing to work with us when we've been able to tell them that they have a number of cases. In fact, some businesses have contacted the public health team themselves. So we've been able to respond early rather than waiting for something to get into a massive outbreak. And, we're lucky as well, I suppose, in York. We don't have some of those big factory food factories or abattoirs, etc., where some of these big outbreaks have occurred. So we've been quite fortunate in York that we've been able to dive onto these cases that we've had and deal with them very quickly.
Mm-hmm. In terms of sites that are offering the tests currently more broadly, do we still have them at St John's? I know that obviously the main universities offering them. I'm just thinking more of central location. Obviously we've got Poppleton Bar and the University of York, and I know St John's was doing them. Are they still doing them at St John's?
Yeah, so we're working in partnership with York St John and University of York. So They're an integrated site. They're offering sites to students, but we've also, they're working in partnership with public health and offering tests to residents as well. It's a really good example, I think, Councillor Warren, of, you know, integrated working across the city. So both of those testing sites are there, and we've agreed with both the universities. Those sites will be open to residents until the end of March. Obviously, then it will depend with students returning whether there's capacity in those sites. So those are both available, and then we have the community stadium site as well.
And if obviously if students are returning, that might make it more difficult. Would there be an active search then for somewhere more central?
Yes, we would look at our case numbers at that time. We would look at the demand for testing, and if we felt that the demand was still there, then we would be looking for another central site. In fact, we're already having some discussions with partners within the city, just to kind of keep our options open, really, if we had to give up the York St John's site for students, what other city centre site might be available. So we're already having those conversations.
Okay, thank you. Any final questions, members? I think we're probably we've had an opportunity, and thanks, Sharon, for all the myriad of questions you've had on this. I'll take a bit of a steer for members now. Do you want to go straight into the next agenda item, or would you like a short comfort break? I'm happy to go with, yeah. So what would you say, 10 minutes? Yeah, okay, so it's 1901. Should we go for 1910 if we can make that?
Thanks.
Yeah, okay, all right then. We'll take a short break. Hello and welcome back to the City of York Council Health and Adult Social Care Policy and Scrutiny Committee. We're just about to start on agenda item 5, which is the commissioning update on the care market and capacity requirements for the coming period. And Pippa Corner, who's the Assistant Director for Joint Commissioning, is going to introduce this item. Good evening, Pippa.
Good evening, Chair. Thank you. So the report in front of the committee is one that I've prepared a week or so ago, answering a general overview of the care market as it is at the moment and how we're approaching what we're going to need in coming months. So if you're happy, I'll just sort of briefly run through it. There are a couple of things I wanted to draw attention to, and then obviously there's a chance for some discussion.
Thank you.
So I'm sure many of you will remember that in previous years, my colleague Gary Britton has come regularly to give a presentation or a report about quality standards in the care market, and with an overview every 6 months. Would have been due to come in early 2020, but that was deferred due to the pandemic. So we'll start to do that again more regularly once life returns a little bit, or business returns a little bit to normal. But those reports generally focused on the CQC ratings. So at paragraph 4, I've just given a quick snapshot of where we were at when I wrote that report, which was that 74% of residential and nursing home settings were good, with 8.6 outstanding, and 17.1% was requiring improvement at the time. And community settings, which broadly speaking is domiciliary care, but includes supported living. At that time, those numbers were correct, including provider, just one provider that was rated as inadequate at the time. But I'm really happy to explain that since that report was prepared, actually that has shifted. So when a provider requires improvement or inadequate, we work quite closely with the Care Quality Commission and with the provider to consider what the improvement action plan needs to be, and to carry out enhanced monitoring and support and have very regular contact. And as a result of that and the re-inspection, that provider has now moved to requires improvement. So it's a program of continual improvement for all providers, really. So that picture has just shifted to the better a little bit. So I hope that's helpful to know. I tried to describe in the report that although we talk about commissioning, actually this is about relationships, it's about partnership working and creating the right environment for all partners to deliver their part of the business as well as possible. We think about it less as purely around transactional activities to do with purchasing services, and much more about understanding what our whole system needs, what our community wants, what people are looking for in terms of the type of care and support that makes sense to them, to allow them to live a good quality life. And then working with partners and providers to develop and redesign that as time goes by, and to understand how we can do that within a reasonable budget. Overarching, the council plan and the health and wellbeing strategy is for every resident to enjoy the best possible health and wellbeing throughout their life. And a big part of that is around prevention and mobilising the assets in the community. So our role in commissioning is to collaborate with partners to achieve that for the population. When we're thinking about care and support for people who need it, our principle is home first. So people should be able to remain in their own home and live as independently as possible for as long as possible. And we've talked about that quite a bit previously in this arena. And you also are aware of the survey of older people in York about what their aspirations and expectations were for the future. And only a very small proportion of our population aspire to going into some form of residential or nursing care in the future. I think people may acknowledge that it's often a necessary form of care and support, but it's not what necessarily people look forward to. So alongside with supporting people in their own homes, we're also thinking about how can modern technology help people to remain independent as long as possible, and how can we use modern technology to reduce isolation and loneliness and to connect people up to their communities. Over the last year or so, we have successfully reduced the new admissions to care for older people, and that's been a concerted effort. It's been deliberate. We've worked hard with partners to achieve that, particularly in relation to discharge from hospital, so that we're getting more people back to their own home. The pandemic has obviously affected that, because it's been absolutely critical that we were able to support people to leave hospital in a timely way, and under the hospital discharge policy requirements under the pandemic, we've had some different business processes and some different ways of funding that care, but ultimately it's still the goal to get people back home. I talk a little bit in the report about market shaping, which is a responsibility or a duty on the council, which other organisations don't have. But it's one of those bits of jargon, I suppose, that if it's not your day-to-day business, it's not obvious what market shaping is. But it's really about a leadership role, influencing and driving pace in the whole market, so that providers are developing and delivering the kind of care and support that people need, and promoting well-being. So I've included some definitions from publications, and want to describe a little bit about the way we do that. So we meet very regularly with representatives from the care sector, either individual providers or as a group. We try to describe where we see services going in the future, so there's a direction of travel for our partners. And in the past, we've published the market position statement. The last one was 2017. We were in the process of collaborating with the sector to publish a new refreshed version, and unfortunately that's been a little bit delayed, but we're returning to working on that now, so hope to publish that before too long. And then this illustration, which comes from a publication called What is Market Shaping, sort of just describes actually all of us have a role in that, including the council, including CQC, but actually also people that train the professions and the workforce, individual carers, GPs and such like. I know members will be interested in the cost of care, and we have in the city a higher proportion, as you're probably aware, of people who fund their own care. So usually we describe it as around 65%. And we also have always had very high occupancy in our care homes, and that has affected, I guess, the weekly price that homes charge for care. The table at paragraph 18 sets out the current agreed council rates for care, and we would aim to place people at that weekly rate, but you'll also be aware that many providers charge more than that, and also based on a person's care needs, sometimes care will cost more because of the amount of care and support that's being provided to that person. In 2019, I think I've previously spoken to you about the work we did with Venn Consulting Limited to look at what the overall capacity and demand requirements were for unplanned and urgent care in York. And the next two illustrations at paragraph 20 are taken from one of their presentations. And what this work helped us to do is to understand, was our hypothesis that we needed more beds in the city correct or not correct? And actually what we learned was that in fact, really our big gap was definitely in care to support people at home, both longer term and short term. And that helped us shape our planning with partners and to refocus where we put our efforts. And I think it was really helpful that we had done that work in 2019, so that all partners in the city who'd contributed to it understood where the pressures were and how they'd come about. And obviously it's more complicated than simply saying we needed more care for people in their own homes, but that was really where the main thrust was of how we wanted to re-energize the system. And at the start of the pandemic, with the Coronavirus Act in 2020, the government set out the hospital discharge service requirements, and that set out these 4 clear pathways that are on the illustration at the top of page 15. And the focus of those pathways was to get people home first. So you'll see that 50% of people were expected to go home from hospital. This is the over 65 age range. Were expected to go home actually without any need for care and support from formal services. And then the next 45% were expected to leave hospital and to get home with some support, but not a long-term support package. And really only the most complex 5% of people over 65 being discharged from hospital should need a care in a bedded setting, as they refer to it. And that was helpful and reassuring for us, because we had put a focus on helping people to get back to their own home. It was really positive to see that as the national expectation, and a lot of the effort and advice going into making that happen. Another thing that we've done with colleagues in the CCG and across the sector is to promote the capacity tracker. And that had been something which the CCG had asked us to support in the previous year or so. And actually that became a really important tool during the pandemic for being able to sort of understand where the pressures were in the system, where some of the risks were around things like workforce and personal protective equipment and such like. And so we were very fortunate that as we entered the pandemic, we had almost full compliance with that system, which is a way in which care homes and care providers update centrally a database around how many beds they've got available and what other issues there are in their home. We've previously shared with the committee the Adult Social Care Action Plan and the Winter Plan that needed to be submitted under the pandemic arrangements. So you've seen that previously, and we've continued to develop the work together with partners that's part of that response. So I'm sure you're aware of Peppermill Court, which is a place where a residential setting under the council's registration for people who are being discharged from hospital while they are recovering from COVID-19 and during that 14-day isolation period. And since I've last been speaking to you about our arrangements across North Yorkshire and York, we've also developed what we've called sort of COVID contact settings, or sometimes people refer to them as amber settings, where people have been exposed to COVID-19 but not tested positive. So it's not clear that they have been infected themselves, but it's a risk that they might have been. So we converted part of Haxby Hall to do that on a temporary basis, because people only need to be there during that isolation period of 14 days. And during that period, in fact, Haxby Hall experienced an outbreak, and we've worked with another care provider to provide a similar kind of support in the city. The other thing I want to mention is that one of the things that has been really interesting about the last several months, the last year really, is the degree to which partners have worked across North Yorkshire and York as a system. So where we have resources, we share them and they're available to our partners, so that we don't want people waiting in hospital if potentially somebody from North Yorkshire could come out to Peppermill Court. That's where they've come to. And it's been good. It means we've reused resources really effectively, and it's cut down on any waste in the system and has helped make sure that people are in the right place at the right time. We've invested in a significant amount, an extra 2,000 hours a week in care at home, different types of care at home for people since last April. And that's a major enterprise. It's always been difficult to recruit workforce for home care in the city, but actually in the last year a number of agencies have found it easier, and I would assume that is because of the changing work patterns for people as a result of lockdowns and the impact on the economy. We've achieved an awful lot, so I sort of have drawn some conclusions towards the end of the report about the wide range of activities that we've undertaken. And I think the emphasis, as I say, is about the way in which we've worked in partnership to turn things around really quickly. And there's something about the way we've been expected to operate during the pandemic, which has made decision making quicker and people willing to work together, at pace in a way that was perhaps not so much expected or not so easy in the past. And we've spoken here about the amazing dedication of social care workers, people working in the health and social care system, and our recognition for their courage and dedication and selflessness through the pandemic. And I'm sure that's something that we still feel really strongly and would want to acknowledge here. It's been tough, you know, in some of the homes, and it's been tough for home care workers, but they've done amazingly well in York. And we talked a little bit earlier on about infections. We had an initial number of outbreaks in the first wave, but over the summer, during that period where Sharon's graph showed that sort of very low level of infections across the city, we had long periods without any infections in homes at all, and the only cases we were finding were through this routine whole site testing, which was not because of somebody having symptoms, but just every 6 weeks we were testing and picking up 1 or 2 staff across the city who had become infected and had no symptoms. And because we were doing that, it meant that homes were able to get that infection control really top notch, and it wasn't spreading to residents, and it wasn't spreading across staff. As the infection rate in the community rose steeply in the autumn, we did see some cases coming back into homes, but compared to some other areas, the numbers were kept very, very low in general. 1 or 2 homes have understandably had more difficulty because it's such a difficult situation. And then lastly, the vaccination programme you already talked about, but in York, I think all of the homes were offered, all the homes that were eligible were offered their vaccinations ahead of the deadline. So if homes have an outbreak, obviously they just have to wait for the 28 days to elapse before that can take place. But it's been a really, really brilliant combined partnership activity. Hope that's a helpful whistle-stop tour of the report, and I'm sure you've got other questions which aren't the ones that I've put in there, so let's see what happens. Thank you, Chair.
Thank you, Pippa. Thank you, Pippa. Before I open to members generally, I just want to ask a question. That you've referenced Peppermill Court a couple of times. And obviously, we've seen how properties have been converted with residential care under council registration to enable safe discharge from hospital. Obviously, aware also that Peppermill Court will be lost to the health system, the greater health system in York in months or years to come. I understand it's probably going to be incorporated into St John University. So my question is around that. Should we have venues permanently to keep capacity in the system?
I think what's been useful about the way that we were able to work together at very short notice to bring Peppermill Court on stream is that it created a different type of flexibility in the system. So we responded to the immediate requirement that we had there, which was to safely discharge people who were COVID positive so that they didn't go back to their other care home. And obviously that's turned out to be absolutely the right approach. And subsequently during the autumn, the government required all areas to have what they call designated settings. So we already had Peppermill Court up and running before that became a national requirement. I think now then I might get this wrong, but I'm pretty certain that we have Peppermill Court for a longer period than we at first expected. So we can continue to use that for this purpose for the duration of the pandemic, we assume. You know, I mean, can't really predict exactly how that will unfold. For me, as a commissioner, I think it's really beneficial to have places where people can leave hospital and go somewhere temporarily that isn't somewhere they're going to live permanently. So I think it's quite hard sometimes if somebody's discharged to a care home where you can live permanently, it can often end up in that person never leaving that care home and not ever getting back home again. And that was one of the issues that the Care Quality Commission had underlying the whole system reviews that we had a few years ago, and their report said, you know, somebody never sees their home again because they come out of hospital into a care setting, and sort of that's that. So I think somewhere that's temporary is a really good asset to have in the system, not necessarily Peppermill Court, but that kind of resource. And we're developing options and avenues with providers and having dialogue all the time to think about what's the next best way of doing that. Would it be an integrated setting with NHS colleagues? Equally, there are providers doing interesting and new ways of working with people, so having much more like domestic settings that people can go out to or have respite in for short periods of time. So we're exploring those avenues, and I think the advantage is to have choice and flexibility, probably smaller numbers of beds in different types of settings. And one of the things we've done a lot more of is live-in care, and people going back to their own home but with round-the-clock care at home for a short period while they make that recovery. So obviously then they get back home and life sort of returns to normal a bit. Does that answer the question?
Yes, thank you. I think we're probably in agreement. I think that there ought to be some provision of some description, what that be. Obviously, I'd leave that up to the professionals, but I think it's proven that it's been very more than useful in this particular occasion to have that. So we've got a number of questions. I think almost everyone's indicated they want to speak. So it's Councillor Taylor first and Councillor Culloch, please.
Thank you, Chair, and thanks for the report, Pippa. Much appreciated. I won't lie, I did struggle with it a little bit. I think it might just be the way my brain works. I found it to have a lot of the good stuff in there, and not much sort of openness on where we could do better or where we're not doing well at all. And on scrutiny, I think that's the place for that. But anyway, I've got a number of questions, but I'll spread them out so people don't get bored of me. I want to talk about the agreed cost of care and this exercise that's been done to sort of update that model. I mean, again, this would have been a good committee to share some of those findings on the exercise, especially if we're already at the stage where we can look at those findings. So I'm wondering if you could talk a little bit about what those findings are. If you've seen them, you might not have actually seen them, and what the implications may or may not be.
Mm-hmm. So the process, the piece of work that's been carried out around agreed cost of care was commissioned by the council, North Yorkshire Council, the two CCGs, and the independent care group. Well, actually, not a Vale of York CCG with us, and it was initiated before the pandemic, and the work was on its way as we entered the pandemic, and it involved commissioning an independent consultancy to work with providers through a process which was sort of a structured questionnaire, and it delivered a certain amount of data and feedback at the time, but it wasn't fully completed as we entered the pandemic, and we were starting to look at what intelligence it had delivered. And the picture in North Yorkshire is quite different to City of York. So they were delivering two separate reports, if you like, to the two areas. And it's only in recent months that we've had the draft report back and that we've been able to look at the detail behind that. And a lot of that detail is, I suppose you might say, sort of like it's an accountancy picture. It's very much a financial picture and breaking down what costs are, as you'd expect, and also what some of the risks and considerations are for providers. At the moment, we're just at the stage where we have given some initial feedback to the independent care group about our picture on that, which is that the intelligence that it's provided is useful, and it does indicate certainly that our current fee rates are below what providers expect and would need in certain regards. So some costs have risen, whether that's workforce or some of the utility type costs. There is always a a fair and reasonable profit margin involved in the independent care sector, as you'd expect, and also the value of property has an impact on the assets of the organisation or the provider. So all of those things have an interplay, and then because the market has actually changed quite a bit in the last year and the circumstances have changed, part of our feedback is that we need to see that information alongside some of the other things that have changed in the last year. So we're just at the stage which I would say is still behind the scenes and confidential, if you like, because they're sort of private conversations about how we understand that information and what the sector's view of that is at this stage. So we haven't published it, is what I'm saying at this point. We can definitely come back and brief the committee around that at the time that that's available. Overall, I think it's probably fair to say that the implications of the exercise are that costs will rise, that our current sort of fee rate is below what their actual cost of care is. So at the moment we have a situation, not just in York, but nationally, where people who fund their own care are paying a lot more than councils are paying for a bed in the same home, for example. So somewhere along the line, we need to bring those closer together. But in the context of very significant budget pressures for local authorities, that's difficult to achieve. And then we also have the element that is linked to nursing care and the NHS funding of care. So all of those things are brought together and we need to look at them as a whole system rather than one organisation just talking to one provider. But what it does allow us to do is to talk to the sector as a system rather than just individual conversations with individual providers. So we should arrive at a place where we say, yes, this is a fair cost of care for a particular level of service that somebody needs. And then if they have higher needs and it's more complex, you can see that you're building on elements for that, which can be transparent and published.
Thank you, Chair. I've just got a supplementary to that, if I may. And thank you, Pippa. It would be really interesting to see what this looks like when we're able to see it. This is probably quite sort of crude or flippant language, but I look at this the same way. It's almost like the social care equivalent of affordable housing and like the minimums that we need to deliver or whatever. And there's issues with that type of formula or approach, and I'm sure there's challenges with this one. And I guess my question is, and I don't know if you'll be able to answer it, is there any, I'm sure there is challenge, but to what extent do we challenge independent private providers when they say these are our costs and this is our profit? How do we know that some of those classifications aren't being toyed with one way or another to look like that cost is higher than it actually is? I'm sure most of them act in good faith, but equally the market has an impact and so does the drive to make a profit. So that must lead to an interesting dance from time to time, or does it not?
I think it is a hugely complicated area of business, both for commissioners and for providers, and for families and people that are in care. You know, that's the other part. It's that human element which makes this sensitive, I think. But yes, so providers will have the ability to break down what makes up their weekly cost, and sometimes the environment they're delivering the care in, you know, is clearly of a really high standard, or a higher standard than other areas. There might be more space, it might be in a particular location, which can increase the cost. But sometimes, you know, we might say that the most expensive placement isn't necessarily, just by dint of being more expensive, the better quality. So it's all about that interplay of things like the amount of care that's being delivered, the wages that are paid, you know, the price of the property, the utilities, any business that is made up of lots and lots of different strands. And one of the things the exercise sort of brings to light is that some providers actually have quite low costs in places, to the point where you think, well, is that right? Have you actually taken account of all your costs? So we try and understand intimately what it is that's influencing that, and to work with providers. But for example, when the national minimum living wage went up, then all providers are affected to a degree by that increase and by competition in the marketplace for workforce. But we don't really have many providers in York, if any, that actually pay the bare minimum. Most providers pay above the national minimum living wage, certainly in home care. So we might make some assumptions around where the costs come from, but actually it's that unpicking it down to individual providers for that explanation. And it just what I didn't make clear is that not all providers participated in the survey, so it's not obligatory. So we only have a sort of share or a proportion, a slice of the market to try and understand that. So then we try and use other intelligence that we have around that.
Thank you. Cheers.
I'd kind of like to ask quite a rudimentary supplementary to what Councillor Taylor's just asked here, and it might sound a bit brutal. Do we specifically ask these care home groups or independents to share their profit figures so that we can see whether we believe their fees are reasonable? And if they're not prepared to do that, then is there potentially a conflict of interest in them being involved in the process?
So I hesitate to give too firm an answer, because I wouldn't want to give an answer that's not accurate. But we do have an understanding of the profit margins of the sector in general and of individual businesses. I think that information is understood, and there is an assumed level of profit which the model expects. And any model, like the one that we're using, is one model, but there are other companies that do similar exercises. They'll all have a level of profit built in, because it is a business. I think the other thing is that providers are not all the same. So some providers are able to support people who have much higher and more complex needs than others. And they'll do that by having potentially a higher staffing ratio or a different physical environment that makes that easier. Or they'll have a different kind of cohort of residents where they can care for, people with similar needs in similar ways. And often when we make up higher fees on a weekly case-by-case basis, that might be because somebody might need one-to-one support. So if somebody needs one-to-one support and that's assessed, and the social workers, or if it's a continuing healthcare case, the nurses assess that as correct, then that does build into the weekly fee. And some people need more than one-to-one support, so it's a combination both of the kind of the basic commercial process of delivering care, but also the individual care needs of an individual resident.
Okay, thank you. Councillor Culloch, please.
Thank you. Pippa, let me begin by saying thank you. Thank you for this report. Thank you more than that for the tremendous work that's been done by all those in this sector over the last year. And I'm sure everybody involved is completely exhausted at this stage. And the way in which partners have been able to work together, it's been interesting to hear how much of that was already set up in 2019 in a way that has surely helped in coping over the period of these last months. I'm particularly interested when you say, and I'm just reading from the report here on page 16.28, home care providers and agencies have had greater success in attracting new recruits during the pandemic, presumably as a consequence of the economic impacts of lockdowns. We need to ensure these new entrants are well supported and encouraged to continue in the field once the immediate crisis is over. How?
I don't know if you probably are aware of Skills for Care as an organisation that oversees the sort of leadership and support of the social care workforce nationally. So Skills for Care and organisations like CQC, as well as the training organisations, actually have a huge range of resources to ensure that staff are well trained in the first place, that they understand the roles they have, that they know how to ask for help, they've got the right skills they need. Because the way to support people in these really important and sensitive roles is to make sure they feel confident, well supported and skilled for the work that they're doing, and well remunerated, fairly remunerated, you know. But it's not, I think most people who come into social care either quickly realize that this is actually their vocation and they want to continue in it and they wonder why it took them so long to find it, or quite quickly will realize actually this is not for me and I'm going to struggle. And there probably are some people who are on the borderline, but the people that have a vocation, it's not just about the money, but we do need to pay people fairly. But what makes the job positive is that you have autonomy, you feel confident, you're part of a team, you can see really brilliant outcomes. So we need to celebrate some of that positive success. Some of the stories around how we've helped people get back home, say from hospital or from Peppermill Court, you know, they're really touching human interest stories, and I probably should have put some of them in the report really. Ooh. But you know, it's actually that bit that makes it matter, isn't it? That sense that you've made a difference and that you've been part of a campaign nationally and internationally to get on top of this pandemic. So I think there will be people who've come into it thinking, I've got no option, this is all I can do now because my normal job is gone, but who actually, if they have the aptitude and a caring disposition, we can really support them to find a career which is fulfilling and rewarding and makes a difference to society. So I do think it's about pay. I think principally it's about training and teamwork and being part of an organisation that respects and values you, and also that the customers you work with show respect and value as well. And it's a team thing, really. I think that's what I mean by it.
Thank you. I'm sure it's a societal thing as well, and I would hope that the appreciation that has grown over these months for the work of carers continues, and they receive the recognition that they truly deserve. Thank you.
Thank you.
Thank you. Councillor Heaton, then Councillor Perrott, please.
Thank you, and thanks, Pippa. Actually, just to follow on the previous point, obviously looking at what's going on within those organisations, is there any sort of strategy going for long-term recruitment, obviously beyond this sort of, you know, people coming in because of the pandemic?
Yes, indeed. Yep. One of the things that we were able to do fairly early on was to launch a new approach supported by the council around using social media and Facebook and such like to help attract new entrants, and working with providers to recruit through various channels. So the council supported that, and I would expect that really to be a long-term change. And when I've heard some independent sector providers talk quite inspirationally really about the range of different ways that they identify suitable recruits, it's not like in the olden days through putting an ad in the paper or putting a notice up, you know, it is much more around social media and personal connections and finding people who've got the right, like I say, attitude and aptitudes. It's also about who we, you know, like how we educate people and what courses are put on and what kind of frameworks there are around employment in these fields, so that people are part of a network supported community of workforce, really. And I didn't mention it before, but if you think about nationally, there's been a lot of discussion around PPE and people having, you know, feeling safe at work. Those sorts of things are really important to how we hold on to people and make them feel positive about the work they're doing.
Yeah, absolutely. I think this is another area that has sort of gone along with recruitment into children's services as well, which you know, there's quite a bit of crossover there in terms of, you know, the kinds of people and how we can actually attract them. Just briefly on the on the market position statement. Forgive me, when we're looking at it being published in 2020, what is that the normal sort of time period that the development will go into it, and so it comes on a roughly 3-year cycle, or is it responding to demands?
No, I mean, ideally, I would have said we would have wanted to refresh it every year, in fact. So when it was published in 2017, it was published in a format like a book, like a PDF. Either you could download it from the website, or you could have a hard copy, like a lot of the publications councils have done in the past. And the intention was that we would refresh that fairly regularly. North Yorkshire have a model, and a number of other councils have a model where it's all online. And I think that's probably the direction that we'd be going in. So we were looking to do something which could be printed, but actually was much more of an online presence for the council and partners. And you'll be familiar with the Joint Strategic Needs Assessment, I'm sure, which is where much more like that approach, where you have elements of it that can get updated. You don't have to update the whole thing just once every year or once every 2 years. You keep continually working on it and developing new elements, and then going back and retracing steps. So our aim and aspiration is to work much more in that way, that it's something that should be ongoing and growing and evolving all the time.
Brilliant. And then just the final one from me, if I can. Looking at the, so working backwards back onto paragraph 4 in the CQC ratings. Obviously, good news that we've seen some improvement, and these things are always a continuous improvement journey, aren't they? I mean, just looking at the ones across the board that are in requires improvement, just in terms of the CQC reports, are there any sort of particular trends that come up, particularly think about the sort of like the headline sections of the CQC reports, or is it very much individual?
The way that CQC inspect is that there's quite a wide number of standards under the domains. So there are different domains like well managed, safe, so well led, safe, etc. So under each of those domains, I think there's 5, there are then numerous different standards that get inspected and rated, but they don't rate every standard of every domain on every inspection. So that that would just be a mammoth task, wouldn't it? And when you go onto the CQC website, if there's a provider you're interested in, or that you know of that's part of your ward, then what you'd find is that their most up-to-date report covers a certain number of issues, and there'll be a narrative around that and a sort of rating, and then that will get re-inspected over time in a sequence. And providers where there is, if you like, a greater cause for concern will get inspected more often, and they'll go back and revisit those areas that have been a concern, and probably other issues as well. But where there is something that's inspected and is not of the right standard, the provider must develop an improvement plan. And as commissioners and contract managers, we are part of that dialogue, both with CQC and with the providers. And for that matter, listening to any complaints or any issues from families, and also positive feedback. So you can post positive feedback on the CQC website as well as complaints. So it's not quite as linear as that suggests. So at any one time, you'll have a snapshot which is not a total picture of the sector in any area. Does that make some sense?
Yeah, no, absolutely. So essentially, we're not seeing any areas where safe is coming up quite a bit, and there's something we could have a broader strategy on, or anything like that.
If that were happening, it would already be the focus of safeguarding activity across the system, both with the council, the CCG, and with Care Quality Commission and the provider. That does happen, and we have processes in place to manage and lead that, and to make sure improvement happens. And one of the things that the CQC can do is to say no more admissions, but equally the council can say, or the CCG can agree that we're not going to make any new placements, for example, somewhere until they have met the standards that we expect. And that doesn't mean to say it's not safe for people to be there, but it might mean we don't want them to have any additional people until we're really confident that they've resolved the issue. Now, we can present more information around the ratings. In this report, it was a memory snapshot, if you like. But what I was saying was that my colleague Gary, the head of commissioning, used to come 6 monthly and present a much more detailed picture of how those ratings break down across the different areas of care.
Good stuff. Thank you.
Thanks, Pippa. Obviously, you've mentioned that Gary has historically brought the 6 monthly stats, if you like, and I think that would have been useful in this context to see, so that we could compare historic data. So that would be something I would expect in a normal report, so that we can see, how York's progressing, if you like. So, for instance, over I don't know, a 10-year period, for argument's sake. That would be something I'd expect to see in such a report, really. So that you can compare.
Yeah, were you expecting it in this report? Because
no. I appreciate that. You've been asked you were given a huge amount of notice for this one. I'm appreciative of that. But in the kind of usual reports we'd expect, in the ones that you referred to that Gary would bring, expect that kind of data there.
Much more detailed and focused. I think Gary would probably nudge me and say the way, like the inspection has changed over the past 10 years. So I think the current inspection model is probably about 3 years old, the framework, maybe a little bit older.
Right.
So the comparison one would make might not be fit for purpose as long ago as 10 years, but
right.
certainly what you would be able to see is how that inspection framework has developed and improved services over time.
So we can begin to get a picture over a longer period anyway.
Yeah, definitely. So, we can certainly schedule that in. I would prefer it to be probably a little bit later into the late spring, early summer, because we're dealing with the much more imminent situation at the moment.
Yes, I appreciate that. Yeah, that's fine. Thank you. Councillor Perrott next, then please. Then Councillor One.
Thank you, Chair, and thanks, Pippa. I've got a couple of questions, and I'll start off with it's a bit of a tricky one, I guess, for you, but how do we model for sort of unanticipated care costs within our commissioning sort of cycle? So I'm thinking around potential uncertainty around what the agreed cost of cares will end up being once we've undertaken these exercises, and for other bits of complexity around being provider of last resort. So if a care setting did end up sort of needing us to rehouse anyone for any reason, or when self-funders sort of reach the end of their own funding and then have to rely on the council to try and place them within agreed cost of care, and that doesn't always happen, does it? Because I think that there's a tendency to leave people in the place that they're currently residing in if it's going to be disruptive for them to move. So I suppose it's how do you build in that capacity, because it must be really difficult to actually sort of plan for these eventualities, not knowing at what point people are going to stop having money to self-fund and so on. So I don't know if you can talk us through what your approach is to that, please.
Well, you got it right. It is really difficult. As a population, we would have a typical year. So we know that obviously some people enter care for the first time and some people pass away. So the numbers of people going through care, it fluctuates, but it's sort of understandable. People's ability to fund their own care is probably fairly consistent in a place like York, where people have property and property is worth a lot, and that affects their ability to pay for care. As a rule of thumb, we normally expect people, if they're entering care in old age, I assume that's what we're talking about really, so older people entering care would normally probably spend the last 2 years of their life in a care setting, if they're entering for that reason. And if people enter care too soon and are in care for too long, they probably will end up costing them and the council considerably more than perhaps would be ideal if you're only talking in financial terms. Usually people are entering care. Sometimes people enter care because a crisis has happened and we didn't have a plan that stopped them going into care. So one of the things we try to do to work really in how would somebody plan for a crisis and how would they manage that to avoid them going into care unnecessarily. I spoke a little bit earlier on about having models of care where you can't go and live permanently because you've come into a crisis. So some of the models we're trying to develop that are much more homely and individualized are also about creating a sort of safe cocoon around somebody in a crisis, but then helping them get back to their own home. And I would think of that as a really good way of not just managing the cost, but actually managing their experience and it not being dramatic and painful loss that they're going to go back, somebody back on their feet. The more people can live independently and live a good quality of life, then the better it is in terms of financial efficiency for them and for council. But undoubtedly, the cost of care is a really significant pressure for the council. Adults care is part of that picture of financial pressure, as we know. We try to work in a way that is around partnership and collaboration and relationships, provide that we can see ahead about the business is going to look like and how we can plan together, rather than a sort of polarizing oppositional contractual relationship where it's all about all we're going to talk about is brass tacks, because actually these are really complicated to run as well. So now I think probably our ethos shifted towards this is a whole system, and certainly what's happened over the last year must have proved to just about everybody in society that this is a whole system and we have to respect each other's roles in it and work together for the better end. Because actually as well, not necessarily logical to have people in when they're ready there. Having a good flexible range of choices for people to have the right care at the right time in the place, that is the answer to managing how expensive it appears to be on the balance sheet as well.
Thank you, Pippa. Could I just ask a quick supplementary, Chair, if that's all right?
Sure.
Thanks. So I suppose it's more about how we're working with providers sort of for things that are on the horizon then. So I'm thinking sort of integrated care systems, all of the changes that have been sort of mooted for health and social care legislation. And I suppose it's how we're sort of shaping the market when we're sort of outsourcing care rather than being providers as well, because obviously like we could build in capacity if we had the system sort of in-house to some degree, like the sort of care model you were describing in Peppermill Court, if it's something that we have control over and we've seen the benefit of this, but how do we go about sort of encouraging providers to deliver that kind of model of care where it's very much sort of step up, step down, and it's not a guaranteed sort of flow through of people when they rely on capacity rates that have been about 98%, I think it said in one of the reports.
Mm-hmm. Yeah, historically that's right. So I think that it's not necessarily a given that it's going to be more cost effective for the council or the NHS to provide these things ourselves, or the better quality of ourselves. I think that's something we have to work really hard together to develop plans that make sense for everybody. And one of the ways that we can work with the independent sector is to provide some stability and continuity in terms of the vision and the strategy. If there's a sense of them having to speculate, that's not a good business to be in. That's not a good market to develop. So we would want to be open and transparent about the amount that we think we're going to need, the length of time we suspect we're going to need these kind of models for, and how we see the future developing, so that partners and providers can see, yes, that's an area of work I would like to do specialism in, and collaborate with us to deliver that, because we know the size of the population that's likely to be affected, the complexity of care they may need. I talked a little bit briefly about technology. So the opportunity around digital technology nowadays are tremendous in terms of ways that we can support people to supplement other types of care. And we've got to work together, because many minds are great one. If we can collaborate together about all the different in which we can make that work, we'll have a system that's self-sustaining and sustainable. You asked about the ICS, so obviously the partnership and integration with the NHS. We work closely together already, and we talk very, very closely all the time about what we think the care needs of the population are going to be. There's been a lot of work that's actually been sponsored by Humber Coast and Vale Integrated Care System around population health management and using population health intelligence to guide some of our decision making. And that's a fascinating area of work that we can only do as a whole system. We can only do it in partnership. One organisation can't do that alone. Thanks, Pippa.
Thank you. Councillor One and then Councillor Taylor, please.
Thank you. So it's related to the sort of 98% high occupancy levels that were referred to in section 17. Is that enough for the city? What can the city do to try and sort of increase the amount of care that's out there? I know that there are some premises in York which are empty, where care providers have moved out. What can we as a city do to try and make sure that new care providers come in?
I'm not sure the question of 98% occupancy is the same as saying we haven't got enough provision. I think we have a flourishing market for care in York. It's not homogenous, so there could be providers thinking, does she know, it's tough. But actually, we have a market where people who are, citizens who are self-funders have a lot of choice about the kind of care that they want to take up and that they wish to. And sometimes I think people will either hold on until they can go to the home of their choice, or they may go in slightly early if they're paying for it because that's where they want to be and they don't want to lose the opportunity to go there. And those things are way beyond the immediate control of any one organisation, and certainly the council, because people have that, that prerogative to choose the kind of sort of environment they want to live in. We would aim to influence that by, as I've talked about, endlessly really open a lot of transparent working with providers, NHS colleagues, and thinking about what does the population look like in coming years. So I referred earlier to that survey among older people, but the older people's accommodation programme devised a whole range of types of accommodation that people will want as they age, both remaining in their own homes or moving to a more suitable property at a certain point in their life, probably more important than going into care. But I think we'll have the right kind of market if providers have enough information and intelligence to understand what is the business opportunity and what will it look like in 5 years, 10 years, 20 years, both in terms of the size of the population, the kinds of conditions that people will experience, whether that's dementia or other types of health conditions, and how can we work together to plan better for that. I think the level of occupancy has meant that it's been harder in the past not sort of really influence everything else about, say, the cost of care. But one of the current impacts of the pandemic is that occupancy levels are lower. So we're having slightly different conversations with providers about their experience of that. And we need to bear in mind that we have many teams working in many homes around the city and the country where teams have lost people and they're grieving for residents that they've lost during this experience. So I'm not saying that to say, oh, it's great, we can drive a hard bargain. That isn't the case at all, but we need to understand that the sector has shifted. Experience is going to take some time to unfold.
Thank you. Councillor Taylor, please.
Thank you, Chair. I want to talk a bit more about us being a sort of shaper of the market. There's been a lot of talk tonight of us and in the paper of our need to sort of mobilise our assets to help do this. I I won't get into the ins and outs of the scandal that happened to the Oakhaven sale under this administration tonight. We'll deal with that separately. But what I do want to know, and it relates to that, but on a bigger level, is how does it work when we have an asset that we own that is designated as being a sort of health or social care building, even if it's not in use at the time, and then another part of the council comes along and says this has got significant financial value as a one-off sale. How does that interplay take place between those, the sort of health team and the social care team versus, if you like, the asset team? And is there any sort of point in that process where officers might think it would be good to let the ward councillors know that this is no longer being seen as a social care venue and it's now going to be seen as a financial asset that we want to get a big capital receipt from? Because, you know, we've fallen foul of that, for better or worse, depending on people's view. And it was just interesting to know that it went from this to that, and we didn't get to see that internal discussion. And it must happen many times. It's not just an Oakhaven thing. We have assets all over the city. So I'm just wondering, how do we manage that? Is there a matrix or a protocol, or is it case by case?
I suspect there's not just one answer to that question, because you're describing an interplay of different sort of issues and policies, and I suspect that there are different answers for different situations, and particularly at different times. And I'm sure if Amanda is listening and wanting to comment, there's space for Amanda to come in and comment on the sort of slightly more strategic and political questions that you're asking. If I think about my experience, I've been at the council. I think when I first arrived, there might have been an assumption that through, say, the Older People's Accommodation Programme, that we might think of stuff as belonging to health, housing and adult social care, and that in the past we had a history and a heritage that these things were ours and they belonged to us, and then it was for us to kind of think about what would we do next then, and would we reuse them, or would we get rid of them, or whatever. And what I've become aware of, and this might just have been my naivety previously, is that actually the council needs to take a much more strategic overview of all of our assets, all of the city's assets, and there may be better opportunities and better uses for those resources, or there may be better opportunities for social care somewhere else that I've never heard of. So I don't know all about the entire portfolio of the council, and I think the advantage is in having that sort of strategic helicopter overview that says, you know, there are better ways of doing this. And in my experience, I think we try to get the best value for the population out of all of the resources we have, whether that's property, whether it's assets, you know, in terms of equipment, or whether it's people. So we're always trying the best we can for local people. So that's difficult, complicated. I can see Amanda's going to come in. Maybe I have or haven't answered that question, Amanda.
I think you've pretty much said what I was going to say, Pippa. I think the only other point I'd add is that, in essence, the two things are separate. So the health and social care aspect of it is around, as exactly as Pippa's been talking about, around how do we manage a market and make sure we've got sufficient types of the whole range of care that we need within that market. And that changes over time. And that will mean that at some point we may not need certain buildings and may need other buildings of other types. And we would do that piece of work only then if we get to the point of saying, actually, we don't have a need for a particular kind of building or a particular kind of space anymore. Would we then say, we don't need that? And then it would revert back to being an asset that could be used in a different way. And that works both ways. There will be times where we might say, actually, there is a different way of delivering a service and we might need a different kind of building. Have we, across our asset portfolio, got that kind of resource available to us? So I think the two things are separate, because it is about the sufficiency of the need of provision that we need to provide. And then we would talk to our asset management colleagues around what have we got or what do we don't need anymore.
Just a wee supplementary, Chair, if I may. Or I guess, I don't know if it's a question or a point. I appreciate both answers, and I know it's not straightforward. One thing that hasn't been covered is the transparency around that. And I think that should be in place no matter what in these examples where there's noteworthy assets in council wards that there may be a conversation taking place around. I mean, on Oakhaven, we specifically asked for an options appraisal to come through scrutiny. That was a sort of one-off, but I think generally speaking, the council could be a lot better in being clear about what's going on before the fact, because then it's too late for councillors or residents to sort of influence that. And as much as, you know, the council officers will have their knowledge and experience, that resident and representative input is still very valuable. So I guess it's more just a sort of point. I think we should improve on that front at the very least.
Can I come back on that?
Yes, please do.
Absolutely. And where I've been involved in similar issues on the other part of the directorate in children's social care, we've absolutely had many meetings with ward councillors. I've been along to ward committees, met with representatives of the community around different use of buildings. So yeah, absolutely.
Okay, thank you. Councillor Perrott, next then, please.
Thank you, Chair. This was something that I'd meant to ask as a supplementary earlier and didn't get my hand up fast enough, so I thought I'd have a little try at the end. So it's going back to the market position statement and how it's being co-produced with the sector. And I just wanted to ask sort of how far we go to co-produce it with service users. So I'm thinking, do we sort of consult with self-funders of care to try and get their perspective on why the costs are very different? Because I suppose my worry about co-producing a document like that with the sector is that obviously, you know, we can ask them for their sort of costs that they think it will have, but it's a little bit them marking their own homework, isn't it? So how much is there the temptation for them to see it as a bit of a blank check to sort of put forward that? And yeah, so if you could just let me know whether or not we're sort of including people who ultimately will be receiving the care and those who are paying for it and at significantly higher rates than the council, that'd be good. Thanks, Pippa.
Yeah, thank you. That's a really good question, and I wasn't very clear earlier on. The comparison with strategic investment is probably still valid here, which is it takes perspectives from all sorts of directions, but definitely in terms of the population involvement, whether they're people that use services or may use services in future, or maybe previous service users. But certainly we do quite a bit to consult and survey current customers of services. We regularly contact people that are receiving, say, reablement or home care and ask them their experience of that service. Regular phone calls made to people and families. The same is true of people living in settings, whether that's supported living or residential care. We ask those questions all the time. We also do some broad surveying of what people think about, and that's kind of like the older people's survey in terms of accommodation was, you know, a more generalized, not necessarily so laser-like in terms of who it reached. We also obviously have good relationships with Healthwatch York, so we're always interested in hearing what some of the messages are that are coming through and the themes, and Healthwatch York would be involved in that process as well, a number of sort of voluntary organisations and providers. So we try and get a really mixed picture, because really there's no point developing services that are no good for people and that they don't want. It's about trying to think, how do you, within all the resources we've got in the broadest sense, how do we get best outcomes for local people? Because that is the whole purpose of us doing this work. So yes, co-produced in the sense of having that dialogue, but also helping us shape how it looks and what makes it accessible and where they want to see it. So it'd be, for example, available through Live Well York, you know, the website, and there's an accessibility standard in terms of what produce. We try to produce things certainly for people with learning disabilities, so that we use easy access information, but actually not just on services for people with learning disabilities, but generally information should be prepared in an accessible format. So we try to do that. Always room to improve. Always willing to learn more. I think the bit that probably is most insight when we start to talk as groups across the sector is understanding where the real tensions are and where the pressures are. And in the past, I would say the biggest theme that comes out every time has been workforce, recruiting and retaining workforce. And I think it'll be really interesting to see whether that looks different in this coming period as to what it looked like a year and a half ago.
Thank you. I don't see any more hands raised, so unless there's any final pressing question, I think we'll probably wrap that item up. And thank you very much, Pippa, for that. Thank you. So we move on to the work plan, pages 19 to 22. It says on the front. Have a look. Right. So for the time being, we're still in the situation where we're having an informal forum once in 3 months and a main meeting once in 3 months. So there's no scheduled meeting, either informal or public, next month. So Tuesday the 13th of April is our next informal date. Now, there's not a huge amount on there yet, but I have had some communication from the chair of CSMC today, and it just making a suggestion which I think would be useful for us to do if members are inclined. So you'll have probably seen yesterday there was an update on the forward plan, item 29 it was, for plans for the future of health and care in York, which will be, there'll be a paper brought to executive on the 18th of March. Now, I appreciate our April meeting is after that, will have already gone to executive, but there's an opportunity for us, even though it's after exec, to perhaps have a look. We could even possibly consider inviting the executive member and other relevant officers to speak to us about the plan. And then there might be some areas that committee might want to look at more specifically for ongoing monitoring as it's implemented. So that was a suggestion, and I think it's a sensible one for April, if you're in agreement. Are we seeing the 1 or 2 thumbs up and nods? Okay, so we'll ask for that for April, and obviously we'll be having COVID updates for some time, I think, and the April meeting will be no different. With May, we've got a couple of items in there already. One of them we had hoped would be at this month's meeting, but as things happen, we've had a fairly lengthy meeting anyway with just the 2 main items. So it's probably not such a bad thing, but we'll have the all-age learning disabilities strategy and an update on the peer review work for reducing admissions to care. We've got a list on the next page of items that we asked to keep a sight of for items for consideration for coming forward. Now, as I've mentioned previously, we are working in cooperation with CSMC about how we manage scrutiny agendas currently. So some of it's a bit of a two-way process, but I'm sure the chair and vice chair of CSMC will be happy for us to make suggestions and pick from these, and likewise they may well ask for us to look at items in more depth as well as from areas that are referred to them. So we do need to keep a little bit of space, if you like, for any such events. We've also got to be still aware the work that our health and social care colleagues are doing around the pandemic and the pressures they have. So I'm conscious, and that's really where we might want to have a real urge to bring some of these reports forward. We've got to be conscious that they're working in real time with some of the pressures around COVID as well. So we just got to keep that balance, I think, which I think we're trying to do, and CSMC are trying to do with the other committees. But I'll obviously let you have some input. Councillor Taylor.
Thank you, Chair. Much appreciated. I just want to say I'm all right with the plan that's laid out at the moment. I do appreciate the position we're in. I want to just put on the record that I'm really not happy with this reduced calendar of scrutiny, and by extension of that, local democracy. It isn't a luxury that we can turn on and off when the times are good and when the times are bad. But equally, I want it to be known that and I'm sure all of us, really appreciate the work of both the officers in the relevant departments and the technical team behind the scenes. I know everyone's working so hard, and my frustration with this reduced calendar is in no way a reflection on those officers. If I actually feel for them at the moment, but this is really not a way for us to be, and the sooner we get out of it, the better. And the administration could probably help us get out of that sooner rather than later if they wanted to. But I just wanted to say that I'm all right with the plan, but let's hope for more rigorous process and scrutiny as soon as possible, because this isn't good enough.
Thank you, Councillor Terry. I share your frustrations, and you've put it quite eloquently, I think. Councillor Perrott.
I too share the frustrations. However, I was going to ask if we could have something just sort of on our long-term radar as well, which is around dementia. So I think we're overdue a dementia strategy, aren't we? And obviously the Dementia Action Alliance thinks winding down in September of this year. I believe that their funding's ending. So it'd probably be good if we could have a bit of a catch up with officers about where we are and what dementia provision is like across the board in the city. But obviously, a little bit further down the line when we're not all having these capacity issues that we've all just mentioned.
Thank you. A sensible suggestion, Anna, and I'll certainly mention this in the chair's briefings that we have as an item that we'd like to look at in the not too distant future. Thank you. Any further thoughts of members on the work plan? No. Okay, that's fine then. I don't have any other urgent business this evening, so thank you very much, and thanks for officers for presenting and staying with us this evening.
Thank you.